So I think now we can go to the panel discussion. So Jeff will join us as a panel member as well as all the speakers. Now, I didn't say that Jeff is in Adelaide, so truly, yeah, Australian. So now we have, thanks to Robin, she's compiled quite a few of the questions, really interesting questions we got from those present here and those on Zoom. So how do we start looking at that? Do we have them on PowerPoint? The first one really, and I get asked this a lot, and I'm sure Julian does as well, and Libby, how do we make compassionate communities sustainable? It's that sustainability question. The second one, not that one. Yeah. So what makes these initiatives sustainable after key people have moved on? And then there was another one. See if the one, do you want me to do it? The one after. You know, this, yeah. So we all start from small projects. Certainly the ones, we started the network before we got funding to do the research project with WACS. But this is a typical thing. So I'm a project lead for a small ComCom in my local area. My role is funded through a small community grant, but the life of this project is only 12 months. And I know it takes longer than 12 months to get community engaged, informed, etc. So has there been any research globally that shows any benefit in having active ComCom leads that coordinate, engage, and educate their local champions, neighbors, connectors who are paid versus the ComCom leads being voluntary? It seems difficult to continue the momentum of this engagement unless some roles are paid due to the considerable time and investment energy required to keep the momentum going. Yeah, so anybody from the speakers would like to answer this question?
Is this not part, Samara, of the wider question of what are the economic, quite apart from the social and emotional benefits of people staying at home and being supported in their home? What are the economic benefits of that? Now, we have discussed looking at a project into that. I mean, if we knew the answer to that, then it would be easier to say, well, then what is the cost and what are the requirements of having the community support that process? Not because it won't just be a cost. You can't look at just look at the cost of this. You've got to look at the savings to government, which have to be absolutely enormous.
Yeah, correct. And you know, from the perspective of paid versus non-paid, yeah, I totally agree. We really need to find a way of this becoming part of what we're doing. So for instance, just to give from the Southwest perspective, the only paid position is the coordinator of volunteers, of connectors. But at the moment, it's the network. After the research project's finished, it's the Compassion Community Network that's trying to find funds to keep that coordinator of connectors going, because she's the one who is getting referrals from the health service, matching the patients to the connectors, liaising with the connectors if they have any issues with the families. And how do we make this a voluntary one? I don't know yet. We're still thinking about this. I think it's going to be difficult making it voluntary. This is where we mean the partnerships come in between the formal and informal networks. WA Health, is this something you can help with in terms of making this as business as usual? I mean, it's all great that, you know, it's been taken up as business as usual, but it's still the community side of things paying for that role. It does save a lot of money for the health service. And of course, when Professor Angus Cook does the, you know, cost effectiveness and the economics, you'll find how much money we've saved, you know, the government by having this program. But it's just one of those things we need to talk to, you know, of course, the health department. How do we get the two working together and each have their share, I suppose, you know, it's a partnership after all. So that's my answer for this. I don't know, Julian or Libby, do you have something on that?
Yeah, I mean, I think there's a couple of things I would say. I'd say, unfortunately, in our kind of current consumerist world, value is often financial, you know, in terms of the value of things people understand and see value if it's funded. And that's, I think, something that we need to push against. But there also is something about how we kind of mark these initiatives, these efforts, these processes as something that really needs to be run throughout all aspects of society. And that if you don't include it in the funding of whatever structure this sits in, whether it's health or social care or community development or community engagement, where this sits, actually it's a fundamental part of building community and building health and well-being. And actually, I think it needs to be recognised as that, and that will make a great deal of headway towards achieving equity. Because if this is something that every community has access to, then actually that's something that then can build, rather than on kind of the hit and miss idea of who's developing it. That said, it can't be something that's entirely, you know, state funded or run, because the whole energy of it is that it is community-led initiative. But how you get that balance of kind of sustainability of a funded role that then can support, catalyze, kind of enable that kind of community energy, I think is important. And I think one of the big things is moving beyond kind of palliative care and moving beyond end-of-life care in terms of sustainability, that actually this can't be something that we are the only people in society who are driving forward, and this must come from much broader elements throughout the general community, throughout different areas of health and social care and policy. And so that's the key to sustainability. We're kind of the early adopters, the advocates, but this must be more broadly accepted. And certainly in my PhD, when I started a project called Compassionate Neighbours, which is very similar to the Connectors, we had a game change when we brought in someone, a paid role in community development worker who'd been working in neighbourhood kitchens and neighbourhood renewal, knew nothing about end-of-life care, but came in, could engage, mobilise, support groups of people within the community to essentially develop agency and change their kind of local conditions. And that's when it was a real game changer for us. So I think paid community development workers are a really important part. And I think Julian's probably got some very important comments to say, Julian, on this point too.
Thank you. I agree with all that you said, and I would add to that is that maybe a way of thinking about this is to see this first of all as a social movement. That this is about the culture of death, dying, loss, and caregiving, and if we think of this in terms of funding, then we get caught up in the problem of building dependencies, because you know, as you rightly say, when the funding drops out, then everything disappears. So if we're thinking about how do we build this as a social movement, and the Compassionate City Charter is a component of that social movement. But then at the same time, as we looked at previously, it's about the integration of professional services and communities and civic sector together. And I think Libby used the right word, is catalysts. So professional services can act as catalysts for communities, but you build in redundancy right at the very outset, because you want that sustainability to come from communities themselves, just because the way that people deal with death, dying, loss, and caregiving changes and communities come together. So I think there's a tremendous difficulty with the financial argument, because you have to get into the mindsets of the people who hand out the money. And good luck with that, is all I can say about that.
And they're here today, which is great.
That is true, but I think if I were one of those people handing out the money, Julian, one of the things I'd want to know, and I know this is a question come up, you know, what are the measurable outcomes that we get out of this? So as a minister, I would want to say, well, you know, what is in it? I get this nice warm glow and everything else, but you know, what is in it for the government? What are the benefits to the people? What are the benefits in terms of the economics of the government, in terms of community development, etc.? In other words, you know, when do we know when we've arrived in the success of these communities? Because you know, they won't go on forever unless we have a damn good business case, and a business case just isn't about money, of course.
I think it's a great question, Jeff, and I think we should be looking at the UN Sustainable Development Goals for answers, because when you take a community development approach, you see all kinds of things happen in a wide variety of different directions. This isn't just about death and dying.
No.
It's about everything in our lives, because it depends where you look as to where you see the outcomes.
Yeah.
And I would further add that Libby brought up the question of inequality. And actually, when you start dealing with issues of inequality, if there was any serious attempt to address the issues that we struggle with across the world, it is really clear that the size of the gap, of the difference between the rich and the poor, give you the worst outcomes.
Mm.
And so this is, in terms of, this is what I'm saying about rationing and reasoning, that when you try and get in the mind of the people who hand out the money, it's really tricky, because the things that help them make decisions are not necessarily the things that make sense to us.
No.
And I think that there is a really difficult problem about engagement. And the other really complicating factor is that we can argue till we're blue in the face that this saves money. But what you see is with healthcare expenditure overall is it continues to rise. And unless you deal with the overall rise in healthcare expenditure, then what happens is, even if your service saves money, it doesn't make any difference, because you have that continual process of cuts. But what I would say is that when you look at applying these principles to healthcare in general, as we've shown in Froome, is that you dramatically reduce both the overall healthcare cost and use of healthcare services. But even in that context, arguing with commissioners about that is a very tricky business. But anyway, there you go.
Great, thank you. I think we've got a few more questions, but while we're at it here, the audience here, would you like to ask a question? Because I think most of the questions have come from Zoom, right? Yeah. Anybody has a bit? Yeah, Grace. It's a microphone there. Yeah.
To ask the question that in West Australia and the models that we've been shown today have all happened outside of the metropolitan area. Have you viewpoints on how you can see that working within the West Australian model of the metropolitan area, and that we don't really have the same viewpoints on local government as in the UK, for example?
Very good.
Yeah, that's true. I mean, things seems to be easier to do in rural areas in this space, but so we haven't had the experience yet in metro, but yeah.
And yet the demand and the need in terms of isolation and everything else, in my experience, can be just as great, if not greater, in the metropolitan area. You can be locked in if you are unable to, limited in your movement, etc. The difficulties in engaging in the metropolitan area can be enormous. When you walk down the street and ask who knows their neighbour over the road, and I worry about the answers. So yeah, I think the metropolitan area is a different is a different issue, because the local government, local community, I don't think relates to their people nearly as well in the metro area as they do in the bush. Yeah, where I happen to come from, I might add.
Yeah, but Jeff, I must say WA Health have funded 5 local governments now. Albany, Bunbury, we know that things happening there anyway, but there's Stirling, Kalamanda, and who was the other, Coburn? Yeah, so I think that's a pretty good initiative, and they've provided seed funding for local government to work and with their community to establish compassionate communities. So that's a good start.
Yep.
Again, our colleagues in Victoria have done a lot with that, with Bruce Rumbold and Andrea Greenrod. So things have started, and I think that's probably one good way of starting to engage metropolitan local government and communities.
Might be worth hearing Libby talk about
Yeah.
compassionate neighbours in
I know it was in London. That's right.
Yeah.
Yeah, so I based the project that we started, which is again similar to the Connectors Compassionate Neighbours, and it's around building supportive networks in place around people who are dying or grieving. And we based this on the model from Kerala in India, where they've got mainly rural, but in cities as well, a huge network of volunteers supporting people at the end of life. And there was a sense that it would never work outside of India, that kind of specific context. And there was also a real concern that it would never work in a highly metropolitan place like the centre of London. But we trialled it, we piloted it over 6 years. And actually what we found was when we went out to where people were congregating and where communities were, then we had huge input and huge interest. And you're right, the number of single person households in London is so high. People, many people families have emigrated, moved, died. And so we saw a large number of highly isolated people. But what we found, if we went to lunch clubs, to libraries, to cafes, where people were still meeting, there was a real desperation to be connected to their neighbours, to help, and also the sense that actually of a real acknowledgement of the isolation and that something needs to be done about it. So when we held these open days, we'd have hundreds and hundreds of people come from all different ethnicities, areas, apartments, flats, working, young mothers, students, older people, retired, a huge variation. And we began to talk to people about loss in its broadest sense. And actually what was amazing is it cut across hugely different life experiences, was really uniting. And people came together in these really diverse groups, much more diverse than I guess you'd have in a smaller rural area where people didn't know each other before, but were all living on the same road or in the same apartment block, and came together. And they're hugely resilient, sustainable models that are still going 6 years, 8 years later now. But it was just something that people didn't think would happen because people are living in different structures. But I always advocated that people are still people, whether they're living in cities, in rural villages, people, and the strength and wish to connect will always be there. So if you go out to ask people, would you like to be part of something like this? And as Julian said, we just catalysed this existing wish and gave people a framework to connect on it. And it's been enormously successful. And it's both looking in rural land now and rural and urban areas.
That's great.
Right.
That's great.
Thank you. So I'm going to move on to the next question. And it's about how do you convince palliative care practitioners to actually embed, well, I'll read it now. About the relation between the community and the professional. As a community development practitioner, I believe in the community is the subject to every intervention. I observe that the community has a rich resource of death literacy, such as sociocultural knowledge about death of their heritage. How do we help the community realize their capacity to play a more important role in the current medicalized dying experience? Anybody would like to answer this one? Can I see that?
So yes is the answer to that. And I think that the whole public health approach that's been developing over the last 25 years is really a way of engaging the professional community. And now that public health palliative care is part of the curriculum for the training of specialists in palliative care in the UK. And actually, I think the textbook, the Oxford textbook, is a big help because it draws together all the information for the first time, which is really comprehensive. So as well as there a need to create a social movement around death, dying, loss and caregiving, there's absolutely a need to create a professional movement where people can deal with what I've called the palliative care blind spots and take a whole population approach that sees that death, dying, loss and caregiving is a social event with medical components to it. And that's about the professional engagement.
Can I just add to that, Julian? There's a question that came a little bit after that first question from Bianca, and professionals struggle saying no to people and have to help, but with it comes this kind of this control over people. And I'm just reminded of when we were doing the Death Literacy Index validation, actually when we were doing some of the, preceding that, we did some interviews with healthcare professionals in a country town to say, who could be involved. And the answer of one healthcare professional was, well, nobody that we haven't vetted, because Mary, the next door neighbour, could be an axe murderer. Now, there's a whole debate around the risks associated with associating yourself with large institutions, but there was this real mistrust that somehow, if it was unregulated, it couldn't be of value. And so I think the kind of the response to this idea that that there are two reforms or two places of development and evolution to happen. One's within communities, and the other is absolutely within the professions. As an academic, I can see it moving excruciatingly slowly, but cultural change always is. But I'm sure others would contribute to that point.
Yep. Thank you very much. The next one is about end of life. I think Compassion UK builds community knowledge, skills, and confidence around end of life care. How do we build the confidence of clinicians that the community can be an equal partner?
Which is really what I was getting at, was that it is cultural change, but also there are resources from all over the world that have addressed this. And I think, Libby, you actually, I'm looking at one of the chapters. I think you looked at this a bit, didn't you?
Yeah, and I think I'd also extend this question, the response, to say the frame needs to be beyond palliative care professionals, and actually we need to be looking more broadly at all doctors, family doctors, nurses, social workers, all people involved in health and social care need to be educated within this. And I, say this as a palliative care consultant, and I completely see, I almost have two work modes, my kind of research mode and my clinical mode. And it's really, really hard to integrate this into a kind of pre-fit system, that wasn't designed for this, and there isn't space for that. So you have to create that space. And as Julian was saying, in the UK, we've now got public health palliative care into the palliative care curriculum, which is amazing. And so we'll have an entirely new generation of palliative care doctors who have been trained in this, who understand the rationale, the kind of the rhetoric and the evidence. But I think we've got to make sure that we're educating professionals in the role of community across the life course. As I keep kind of coming back to, death needs to be not seen as this separate and special event. Will be met with the same kind of challenges that we've kind of experienced throughout our whole lives. Now, obviously, there's a huge amount of specific input that's needed there, but we shouldn't kind of separate it off. Only palliative care manages this, or only compassionate communities manage this. It must be seen as, how do we build supportive networks throughout our lives to deal with all the multifaceted areas of loss that we experience in our lives, of which death is a huge one. And that's where some of the sustainability comes in, that it isn't palliative care, because I often see people in my practice for the last week of life, and I can't get anything built in that time. I can't build those sustainable networks. It has to be earlier on, and it really should be prior to serious illness diagnosis, because as Jeff really eloquently said, grieving starts at that point of diagnosis, and you're dealing with something that's changing all the time then, and actually you want to draw on things that are well established prior to that. And so that question is how we begin looking at that throughout the life course, how all health, social, government, council professionals understand these as natural events in our lives, but needing significant amount of support around them.
Yeah, great.
Can I just add something, Samar?
Yeah, sure.
So I'll add it from the point of view of a small town and a small services. I think lots of us in the room are working clinicians, and our spheres of influence seem quite small, but actually that's also a start. So obviously, I have already ordered, by skipping out of this and getting online, that textbook. But I do think that we can all provide leadership within our spheres of influence, and we can ask those questions about, where are those partnerships? Or we can, in our day-to-day clinical interactions, we can continually be coming back to these principles of love, laughter, friendship. Who are those people? We can start to build the questions of what matters most into our everyday histories. So there is small spheres of influence that I think we can all have. And I hope part of what I've tried to do during my practice is work with sometimes those small spheres of influence, and hope that those ripples also extend out, because we are training 1, 2, 3 people at a time, or we are having people come and go into our teams. And I do think we've got the ability to also chip away at things, even if we feel I'm just a doctor in a rural town, or I'm just a nurse on a general medical ward. How can this big thing how can I have any part to play? So I'd also encourage you just to remember that chipping away, challenging the status quo, leading within your sphere of influence, and hoping that the ripples do spread out. So you might be the nurse on the floor, for example, that says, why can't we show that person, their family and their carers out there how to give that injection? You can be the facilitator. You can be the one that gives them some of the information about, what's really important here is relationships. So I'd really encourage you to think about that all of us have a role to play as well, although for many of us it's a lot smaller.
Thanks, Kirsten. You've answered few of the questions, really. Sorry, Julian. Yeah.
I was just, I'd just like to say that, meetings like this, I think, make an enormous difference. And I don't think you should underplay what you've done, Kirsten, because and the work that Samar's been doing, and the work that Luke does along with Joachim and Libby in the big project in Belgium, is that as the evidence comes out about this stuff, we share it amongst the professional community, and that inspires the professional community as a whole. When we look back, we see this as a small practice examples, an idea started by Alan Keller here in the 1990s that has become a worldwide movement, and it continues to grow. And the practice examples of the application of these principles is incredibly inspiring and really helps. So it's not, you may be doing it in a small area, but it has a big impact.
If you started this in the 1990s, Julian, you must have started in your early teenage years.
I wish that were true.
Samar,
Yes.
being an outcomes-oriented side, I think it's been a great seminar. But what I would like is as Aussies, and particularly looking at the Mondos project and the MND people, is what are the issues that we can take out of this? And we can't answer this now, but I think take it on notice, and you might get a small group together before you have your drinks to identify those issues that they need to address, and then engage the great group of people that we got here to further some of those issues, so that we don't just go away being more informed, but we go away being more armed to move it ahead in a positive way.
Totally agree. We've come to the end of our session, but there's one question on Albany project. Would you want to put it? Do you want to read it there?
So I've got it on the screen in front of me. Am I interrupting because I can't hear the person saying the question?
The Albany project had a focus group with Aboriginal people. Were there lessons learned from speaking with them about community and culture from a people who, to me, as an outside observer, have very different attitudes about death as part of life?
Did you hear that, Kirsten?
I did. So yeah. I think in our community, working together, particularly in a research domain or in a policy domain, comes down to relationships. So I think working with the Aboriginal elders here and the Aboriginal young people, we do need to be in a place of trust, because there have been terrible traumas perpetuated. But I think the lessons we've had from this focus group, but others where we've talked about palliative care, end of life, advanced care planning within our region with our Menang people, is that they are very open to these conversations. They have great insights. They can give very clear advice about the best ways to work. They want to solution generate as partners. But I think particularly those conversations need to happen in an environment that's experienced as safe. And then I think our part is about listening. So the lessons we've learned haven't necessarily been the dot points of do this, do this, do this in terms of attitudes to death and dying, but it's more about that general approach. And I guess the real take home for me is working throughout the state of Western Australia is that you have to ask people when you get to where you are, who should I talk to? Can you give me some advice about how to go about that? And you need to really respectfully be guided into those conversations in the forums and places where they can be held. I'd also say, though, that Julian has put quite a lot of really good references in the chat, which I've taken a photo of before that chat disappeared too far, and that there are also some really excellent Australian resources. There is a repository through ECU about end-of-life research resources and other resources for Aboriginal palliative care. There's some great modules from Guandalan at the moment that we've got. And I think many of us now have Aboriginal people working alongside us in our community development or in healthcare. And I think they may well be good places to start, just to talk to people about how this looks to them.
And that sounds great, Kirsten. And I would add to that is I run a podcast called Survival of the Kindest. And I've spoken with quite a lot of Indigenous people on that podcast. And I always feel slightly embarrassed, to be honest, because we have recreated community development, which has often the same language that you find in Indigenous peoples. And they look at us slightly strangely and go, what do you mean we've been doing this for thousands of years? And so there's another way of thinking about this is, well, how do those communities function? And we can ask those questions, and we take the perspective of becoming learners for deep knowledge. And there's quite a few podcasts where we talk about that. It's well worth listening to Holly Prince talk about it. And we spoke with Tyson Yunker-Porter from Australia about it, from Nicole Hewlett, who works in the palliative care space with Aboriginal communities, and quite a few others. And they all, I just feel silly for talking about compassionate communities and community development. Like, oh, yeah, sorry, you've been doing this for a long time.
No, and coming from another cultural perspective, that's exactly what we do. We used to do, you know, all that sort of that kind of work. And again, you talk to somebody from sort of my community, they would look, well, so what's new about this? You know, like we're doing it. Yeah, but anyway, look, I think we need to wrap up. It's been fantastic afternoon. As I'm reading the chat, everybody's saying was inspiring. Thanks a lot for our speakers, John, Julian, Kirsten, and Libby. It's been fantastic having you together.